I would like to thank Dr. Mohammed because of this kind invitation, and thank you for arranging all this. This is a large, a very huge task, and it's highly appreciated. So my talk today is about fractures of the proximal femur in adults. That involves trochanteric and subtrochanteric fractures. My name is Ayman Sorial. I'm a consultant trauma and orthopedic surgeon in North Wales with specialist interest in arthroplasty and arthroscopy of the hip and knee, as well as reconstructive surgery. Before we start, I would like just to commemorate one of my dear professors who passed away this year. Dr. Abdul Mohsen Arafa was a great surgeon and a great personality, and we will miss him. One of the things he taught me is that the competent surgeon is capable of identifying and managing complications. We can all operate, but those who can identify the complications and manage them, this is what makes a surgeon competent. This is what he taught me, and this is what I'm passing on. He will be greatly missed. So trochanteric and subtrochanteric fractures. Previously, my colleagues have given valuable lectures about neck of femurs. There's also head of femur fractures, but I'm going to talk only on trochanteric and subtrochanteric fractures. So the anatomical location is bounded by the trochanteric line, which extends anteriorly from the tip of the greater trochanter to the lesser trochanter. And the most inferior extent is the inferior border of the lesser trochanter. With the subtrochanteric fractures are fractures that do not only occur in the next 2 inches, but also that extend to that particular anatomical location. Now, before we start, I'm gonna bore you a little bit with some talk about osteology and biomechanics. I'm not gonna go in depth with these, and trust me, everything I'm about to say have a very relevant clinical implication. So the proximal femur is involved with composed of the head of the femur, which is more than half a sphere, bears the fovea connected to the shaft with the neck of the femur at a given neck shaft angle. And this neck shaft angle is normally somewhere between 120 and 135. If it's less than 110, it's called coxa vara, and if it's more than 140, it's coxa vulgar. The neck of the femur have also an anterior anteversion, which is normally somewhere between 15 and 20 degrees. Could be more than that, particularly associated with a shallow acetabulum. Could be less than that as a result of a previous hip pathology or a fracture. It's very important to realize the trabecular pattern of the proximal femur, with the weight-bearing trabeculae coming to join the calcar femoral and the secondary weight-bearing group coming laterally. The tensile group with a primary secondary stretch across the neck of the femur and is the main guard against fractures. The main implication of this is that if you are accessing the medullary cavity from within, bear in mind that normally the trabecular pattern can lead you to the piriformis fossa. Whether that's where you want to start or not, that's something different. There is also the anatomical facts of anterior femoral bow, and it's not a very uniform bow, but as for description, we say it's an arc of a circle whose diameter is 100 centimeters roughly. Now this is X-ray, this is radiograph of the lateral projection of the proximal femur. What I'm trying to tell you in this, just bear in mind that the greater trochanter overhangs the neck of the femur more posteriorly than anteriorly. And this is very important when you are accessing the medullary cavity, creating your entry point. You have to take that into consideration. Otherwise, if you go straight in the center, you might be going too posterior in the neck of the femur and therefore end up too anteriorly. The lesser trochanter, there is also bone behind it, which is with the fanning out of the calcar femoral. Other factors we need to consider is the canal flare index. So different patients have got different canals. In younger patients, they tend to be very tight around the isthmus, could be as little as 6 millimeters. With the older patients have generally wider canals, and there's racial differences, and this is dose classification. Biomechanics of the hip are very important, and they are very important for arthroplasty, But you have also to bear in mind that with fractures, they're equally important. The offset is the horizontal distance between the center of rotation of the hip to the axis of the femur, and that is basically the arm to which the abductors work. Now, a single leg stance is very important to understand. This is a type 1 lever where the fulcrum is between the body weight, which acts from above the pelvis and is balanced by the action of the abductors acting from below the pelvis. And the resultant is about 3 times the body weight because the abductors have to generate double the body weight. Now, this is an image that you probably have not come across before. This is by Cochrane in 1980. This is a cadaver study where they applied 100 pounds equal to 445 newtons on a femur. And they have analyzed the stresses where the compression stresses were along the inner aspects, but the most compression stresses wasn't at the neck of the femur, but rather distally within the subtrochanteric region. And the tensile stresses were mostly on the lateral cortex, with the most value being a little bit more proximal. This tells you how much stresses are in the subtrochanteric region. That's very important. The vascular anatomy, again, the most important vessel for the proximal femur is the medial circumflex femoral artery, and the most important branch is the subsynovial branch to the femoral head. There's quite a rich blood supply with anastomosis around the trochanteric region, much better than the subtrochanteric region, where there's a little bit of a watershed area with the nutrient vessel coming from the profunda femoris artery is one of the main blood supply. So let's start talking a little bit, because we've been talking about anatomy and biomechanics. Let's talk about deformity. What happens when we have a fracture in that anatomical location? The deformity is dictated by the hip abductors, hip flexors, and short external rotators. So the distal fragment is pulled medially, being abducted. The proximal fragment is abducted by the abductors, flexed by the iliopsoas, and externally rotated. It is very important, once you're trying to fix these fractures, is to correct the deformity before you attempt fixing them. There is very good evidence that if you don't fully correct the deformity, the chances are that a malreduction of 10 degrees or more in any plane of the 3 planes is likely to increase your risks of non-union and mechanical failure. I'm not going to go through the demographics. Dr. Kirsty have been through this extensively, so this is basically what she's already mentioned, so I'm not going to go there. She made my job very easy. Other etiology. So most of these patients are elderly patients with low energy trauma, but never forget that some of them, 5%, will be high energy trauma, whether that's fall from height, industrial accidents, or road traffic accidents. Sports injuries, stress fractures also happen. Atypical fractures, whether they're associated with the use of bisphosphonates, and pathological fractures. The primary plan was to involve that in this talk, but I must say that this talk is already big enough, so I decided that we probably can talk about this in a separate talk. I think it's big enough to spread out to that. As I said, patient assessment, according to the guidelines that Dr. Hutchinson have told us about. So for high energy trauma, ATLS principles. Associated injuries. Even with low energy trauma, you could have a head injury, and the incidence is about 10%. Bear that in mind, because simply giving a patient thromboprophylaxis in the form of Clexane or anything similar in the presence of a subarachnoid bleed can lead to their deterioration. A full neurological assessment is very important to exclude spinal injury, and the implications of an upper limb injury is very important towards rehab. Never discount associated fractures, whether of the ipsilateral bone or other parts of the body. Always think about whether this patient had long lie, the effect on kidney functions and elevated creatine kinase. Comorbidities are important. Again, I'm not going to go there because we already discussed that in previous talks. It's very important to realize what's the state of activities of these patients. So when I'm talking about the management, I'm going to refer to elderly patients who have had a proximal femur fractures. But again, as I said, never discount that these fractures could happen to younger patients. So this is in the UK, it's a multidisciplinary team approach involving orthopedics, anesthetics, orthogeriatrics, physiotherapists, dietitians, nursing staff. Analgesia is very important. I'm not going to talk about all of the above because Dr. Hutchinson have already mentioned that. Now, let's come to the important bit. Everyone wants to start talking classifications. How many classifications for the proximal femur are there? There are probably about 50 classifications. If we start talking about each and every classification, we'll probably spend the next 2 hours talking about them. There's anatomic classifications, classification number of fragments, subtrochanteric classifications only, and the ones that I tend to like very much is classification based on stability and number of fragments. And there's also modifications of classifications. I'm going to talk about 3 classifications only. So what makes a classification important? It needs to be simple, reproducible, easy to apply, provide information as regards the stability after reduction, guide your method of fixation, and give you insight towards rehab. There has to be a sort of agreement between different observers, and we measure that by the kappa value. So a kappa value of 1 means that everyone that will look at an X-ray will give you the correct classification, which is hardly the case. But with the AO classification, without the subgroups, there is 0.71 agreement with the kappa value of that number. So I'm going to start with Evans classification. And this is a very old classification, 1949. And the main reason why I'm mentioning Evans classification is the first classification that takes into account the appearances of the fracture on traction. And this is a very important thing. So broadly, it's a type 1 and type 2, and type 2 is reverse oblique. And type 1 is undisplaced stable. And we'll go to 4. Group 4 is unstable, comminuted. This is a 2-part, this is a multifragmentary. But look at group 2 and 3. They are essentially the same fracture, with the only difference being group 2 are amenable to reduction with a stable reduction pattern, and group 3, no stable reduction is attainable. Another important classification is Boyd and Griffin, and the reason why I mentioned Boyd and Griffin is this first classification that takes into account the stability in the coronal and sagittal plane, and this is particularly important, as I will explain later. It also identifies the importance of the lateral cortex fracture as evidenced with type 2. But we are going to use the AO classification, which is what we use day in and day out. So it's an alphanumeric classification where the femur is bone number 3, proximal is 1. So A1 is 2-part fractures, and this is subdivided to a simple trochanteric fracture, A11, those who extend into the greater trochanter and with a bit of more displacement are A12. Those who extend inferiorly beyond the lesser trochanter is A13. Now, the other type is A2. A2 is a multifragmentary fracture, so the 3-part fracture is A21. If we have more than 3 parts, it's going to be A22. If the fracture extends medially more than 1 centimeter beyond the lesser trochanter, is A23. A3 fractures are basically subtrochanteric fractures with breach of the lateral cortex, with A31 being the reverse oblique, A32 is almost transverse fracture, A33 is multifragmentary subtrochanteric fractures. This is the classification we use for all trochanteric fractures, and you'll find that in all the guidelines that we use day in, day out. So what is the guidance? Well, how are we going to manage these fractures? The National Institute of Health and Care Excellence says simply that you're advised as an orthopedic surgeon to use an extramedullary device like a sliding hip screw, which is the DHS, for all fractures above the lateral trochanter, which are A1 and A2s. and to use an intramedullary device like a cephalomedullary nail for all A3 types. And that is a very global view. I have many colleagues who abide by that and use that classification and that guidance for every patient. And they're quite right. But is that what everyone needs to do? I must say, what I'm about to give you is more of my view and how I manage these fractures. Now, from across the ocean, from the States, there's another researcher here and gives it an evidence-based algorithm. So basically, for the A1 fractures, they use the DHS. For the A2 fractures, A21 and A22, they use a short cephalomedullary nail. And for everything else, A23 and A3s, they use a long cephalomedullary nail. Now that's an alternative algorithm. I quite like this one because I quite like to think that the A21s, if they are satisfactorily reduced, they would have a stable entity as indeed the Evans classification. So a DHS for all those, and then for the unstable types, which is the A22, A23, and all the A3s, a cephalomedullary nail. I would like to consider the A22 as a separate entity where it can be, where you can use either a DHS or a nail, depending on what type of patient we're talking about. If we have a patient that have got very little mobility and you are going just to temporize him, giving something for some stability for nursing care and was not mobilizing before, you might choose for an unwell patient just to do a DHS, which is a shorter and more straightforward procedure. Again, the timing of surgery is something that Dr. Hutchinson have talked about, so I'm going to not go there. She's explained that in detail. We'll go to the specific types. So A1 fractures. We're going to use a DHS fixation for all A1 fractures. But the counter argument is, why not use a short medullary nail? There's several countries in like Southeast Asia where the short medullary nail is the standard. You will not see a DHS at all. So the argument is, like a meta-analysis by Wynne-Jones in 2006, there was no evidence for reduced failure with an short intramedullary nail in trochanteric fractures. A number of reports have given credit to short nails by showing that they have a shorter operative time and less blood loss, but actually the difference is not clinically significant. There's some actual evidence from the Norwegian register that there have been increased in the rate of reoperation with nails. So why do I choose the DHS? Because this is a recommendation of NICE. Number two, I worry about this particular scenario. So coronal plane deformity is a major problem with these fractures. And Parker in 1993 reported a 28% risk with mechanical failure in varus alignment. So you must avoid varus alignment in trochanteric fractures at all costs. And the reason being, if you are inserting the nail through the fracture site, you're likely to push the fracture and varus. Now, let me put it this way. If you're operating on a forearm and you look at your post-operative x-rays and you find that there is a screw, a 3.5 millimeter screw in the fracture site, you wouldn't like that. You would think, I've put a screw in the fracture site, it's not going to heal. Why is the hip any different? Sharman 2018 report increased risk of mechanical failure with nails with reoperation. And there's a Cochrane review in Parker, increased risk of intraoperative fractures. Now, the main problem is going through the fracture site, and I find this, and many surgeons have got much greater experience with nails, can avoid that, but nevertheless, this remains a risk and needs to be taken into consideration. DHS, it is, some people love the DHS, some people hate the DHS. It's the easiest operation. My first operation ever as an orthopedic surgeon, 1997, was a DHS under the care of my professor Shireen Ahmed Khalif. It's an also very easy operation to get wrong. So you have to avoid coronal plane deformity, correct posterior sag, adequate posteromedial bone contact, and you have to respect the tip apex distance. So as we learn at the levels of evidence that the RCTs and meta-analysis are important, you look at Baumgartner, he's giving us the tip apex distance. This was a retrospective cohort study, and it's very important. So the collective distance from the tip, from the center of the femoral head to the tip of the DHS slag screw in both AP and lateral projections should not be more than 25 millimeters. If it's more than 25 millimeters, there's a high risk of the procedure failure. Use an appropriate angle towards your hip. Not every hip is the same. You should try to match your hip anatomy. You've got a choice of 130, 135, and 114. You should use the most appropriate angle. And assess your lateral cortex for fractures. Why is the lateral cortex important? Basically, if you look at this image here, if the cortex is fractured here, this automatically turns into a reverse oblique fracture. Now, there's a number of researchers that looked at the lateral cortex, and they concluded that the lateral cortex fracture is a very important factor in success of DHS. Actually, there was some researchers looked at the thickness of the lateral cortex as a predictor of the lateral cortex failure, and the thickness of less than 21 millimeters has been postulated. Just to give you an idea, the short barrel of the DHS is 25 millimeters. So if you've got a very thin rim of bone here, there's a good chance that it might fail. Actually, some researchers looked at, in retrospect, on the cases that had mechanical failure, and they found that they could identify a lateral cortex break in 38% of their cases. Now, this is a DHS. This is not my operating. This is the operating of one of my registrars. And basically, this is as good as DHS gets. There's good, careful reduction of the medial cortex. The tip apex distance is less than 15, and that would, if you can get it less than 15 millimeters, you're probably better off than 25. And this is absolutely perfect reduction. Quite happy with that. This is very unlikely not to work. Now, this is another DHS done by another surgeon. Now, where is the problem here? There is a number of problems. This is all risks put in one patient. Now, this fracture has not been reduced. It's been left in varus. The surgeon's trying to get his lag screw as inferior in the neck as possible. So he went with his entry point far beyond the point which is opposite to the lesser trochanter. And therefore it ended up very superior with a tip apex distance of about 35 to 40 millimeters. So this has got trouble written all over it. So this is not the way forward. My advice is, if you're doing a DHS and putting your guide wire in and you find that you're inferior in the neck and superior in the head, think again. This is not going to go as planned. You have to reduce your fracture first. So why the headache? Let's go straight for primary arthroplasty. Primary arthroplasty, if you're an experienced arthroplasty surgeon, yes, by all means. If you can do that, yes. But again, the arthroplasty in the presence of a trochanteric fracture is very, very tricky, and not many people can get this quite right. Because you need your lesser trochanter to assess the height of your prosthesis, and you need your abductors working through the greater trochanter. Now, looking at these researchers, and this is the Scandinavian actor, where they found that the risk of greater trochanter non-union is 22%, which is across the board. Many researchers keep saying the same numbers, 20% non-union of GT, which is symptomatic. And those who had a THR had a very high dislocation rate. So be very careful that the fixation of the greater trochanter, lesser trochanter around an arthroplasty is not easy. And if you think that a cut through over DHS is bad, dislocatable hip replacement is worse. So I've jumped from A1 fractures to A3. So what happened to A2s? As I said, I would consider the A21 as a stable entity if reducible and use a DHS. The A2 to consider on case-to-case basis, and the A23s I would consider as A3. Now, AO have given the spectrum of all these methods to fix these fractures. You can use a short nail, a sliding hip screw with a trochanteric extension plate, a DCS, or a blade plate. Which one of these do I personally use? I use none of these. I use a nail, and I use a long nail. And I'm going to explain why. This is my method of thinking, and this is how I manage things. You've no obligation to do what I do, and every surgeon has to make up his mind how he's going to manage his patients. Why is nails better? Because they have a mechanical advantage. They are closer to where the load is applied. There's less of a lever arm. So biomechanical studies show that the cephalomedullary nail will withstand more cycles, failed at highly forces, than an extramedullary device. And many surgeons have even stated that is the best plate a nail. And these are reputable researchers looking at huge number of patients. We've got also research in Benha by Professor Ahmed, Dr. Hassan Hussein, Dr. Hani Basyouni. I've got an RCT where they compared the results of cephalomedullary nail versus plates, and they concluded that cephalomedullary nails fare better in unstable fractures. So how about the trochanteric plate? Would that replace a nail? So Tucker in 2018 have showed that the cephalomedullary nail fares better, does much better compared with the sliding hip screw with the trochanteric plate. Bear in mind that the trochanteric plate can prevent lateral displacement, but the design is not strong enough to hold on to a fractured greater trochanter, which will end up cranially displacing. Is there a place for that? Yes, if you're doing a DHS and you find that the lateral cortex has broken at the final steps, you could potentially consider to go with that as a salvage procedure. What about the locking plates? And this seems to be where the salvage procedure. But for subtrochanteric fractures, again, as the trochanteric plate is extramedullary, even if with a strong design titanium, they still fail. And the failure rate is quite high, whether that is due to cut through or whether mechanical failure. Is that something that we don't use? We still use them. There's still much uses for them, and there's definitely place for them in failed neck of femur surgery. Now, I've concluded I'm using a nail. Why not use a short nail, which is easier to use, less operative time? You put your distal locking through the distal targeting device. Why bother with the long nail? The short nail is definitely less operative time, less blood loss, but there is a small risk of fracture at the distal screw. I mean, some designs are better than others, but as there's the stem tip together with the distal locking screw, there's a chance they might break in that anatomical location. Of course, the long nail, if you create your entry point too far posterior, you risk anterior perforation, as we can see here. Again, the nails, you've got different designs. Are you going to use a nail that uses a performs entry point? Are you going to use a nail that uses trochanteric entry point or a lateral entry point? The classic performs entry point is also associated with the least stresses on the nail, but nevertheless, the results of trochanteric entry point are quite good. Now, this image here is from a researcher called Gautier in 2016, and they mapped the distribution of blood supply of the medial circumflex femoral artery. Now, it's quite close to the entry point for the performs entry nails to the vessels, and particularly the subsynovial branch, although it's not proved that there is a higher risk of AVN with performs entry nails, but bear that in mind. Again, regarding your choice of nails, we use a blade or a screw or a double screw. I mean, the least to say that the evidence is anecdotal, and there is no one can really say which one of these is better. I suspect the nail that you know best is the best nail to use for your fractures. Are we going to use a reamed or an unreamed nail? I think reaming adds up to the healing factors that come within the fracture, and therefore it's very, I always ream my nails. This is some advice from the American Academy of Orthopedic Surgeons for the use of nails, and the advice is do not accept distraction. Correct your deformity before you even start fixing the fracture. Once you start fixing the fracture, you're not going to reduce it. Never think that you are going to reduce your fracture with the nail. You reduce your fracture and then apply the nail to hold it where it is. Careful alignment of the fragments. Put an effort. Even if you have to do an open approach, you have to go in and try to align every fragment to the best of your ability before you apply your nail. And do not ream before your reduction. There's some unanswered questions. Is there a role for primary bone grafting? I definitely wouldn't do a primary bone grafting in a fracture unless I had a big gap. If there is a small gap, I can use an artificial bone substitute. Is there a value in repairing the greater trochanter fracture with the use of a nail? There's definite value in maintaining the abductor function. We know that patients who have a trochanteric fracture with a floating trochanteric fragment are more likely to have problems with abductor pain and the limp. There's always a chance that this fragment can incite heterotrophic ossification. So if you've got a fragment that you can secure to the rest of the femur using a strong suture, yes, by all means, do that. Now, do we use cables or we don't? Let me make a differentiation between cable wires and cerclage wires. Cable wires, you have this tool at hand, and without this tool, trying to pass a wire around the femur means that you are going to devitalize the femur. The cable wires, passed by this tool, they cause very little soft tissue damage and they give much better hold. Consider that and think about that if you're looking at evidence. Now, Rahmi et al., this is a very recent publication with good numbers with all types of trochanteric and subtrochanteric fractures. And they looked at all the results, and when you look at this, this is quite reasonable. For the unstable fractures, they hardly used any cerclage cables. For the more comminuted, for the more difficult fracture, they use that mostly. When you look at patients and you consider that the risk of mechanical failure is really high, look at these results. So the results are ranging from 96% success with radiological union with the more stable entities, and with those more unstable entities, 94%, which is still quite good. And that is with the use of cable wires, up to 3 of them. Now, this is a case presentation. I would like you to become a little bit involved with me with this. And this is one of my patients where I have operated on this patient quite recently. What do you think the problem here is? If anyone wants to add, I'm more than happy to entertain a discussion about this one.
If anyone wants to make a comment, just write it on the question and answer. And Dr. Saad will drive it directly to Professor Ayman. دكتور سعد حضرتك معانا؟
Yes, sir.
تابع الشات بقى وشوف الانسرز.
Yes, I'm just tracking the chat. There's no questions. Okay, one question from Ahmed Liman, medial comminution. Another one, posterolateral cortex unstable fracture. Would you give attention to fixing the lesser trochanter in multifragmented fracture?
Okay. Any more?
No more, sir.
In my opinion, I think all of you are definitely right. The comminution with the large fragments. I would advise you always to keep an eye on the deformity. The deformity is what will trick you. The deformity is what's going to make your surgery become difficult. look at the amount of flexion we have on the proximal fragment. This is a massive amount of flexion. Without correction of the sagittal plane deformity, this fixation is going to be very, very difficult. The iliopsoas has pulled the lesser trochanter along with this fragment, both medially and anteriorly, and therefore we do not have a tube anymore. And we have to correct all this before we do anything. The problem with the subtrochanteric fractures, you can't really see them on one screen of the image intensifier. So I've taken liberty of collating the images together. So this is what I've done. I have corrected my deformity first. I've restored the tube. I've put a primary fixation with bone clamps. I've done my nail and then substituted the primary fixation for cable wires. Now this is what I believe is the way forward in these fractures. These are difficult fractures, and this is what you need to achieve. You need to achieve near anatomical reduction and stable fixation. Now this is another case. Now, would anyone classify this fracture for me? I'm going to play this. This is a CT reconstruction of this fracture. So I'm going to play this. This is a video. So would anyone like to classify this for me according to the AO classification?
We are waiting for the answers on the chat or the questions and answers.
Yes, we are looking for the answers on the chat, sir.
I'll play this again for you.
Might use super Griffin. I might use super cables. Okay, questions. Yes, yes, there is an answer A33, and another one said that it's A23. Dr. Ayman, do you hear me?
Yeah, I can hear you. I would definitely agree it's an A2 because the fracture seems to be above the lesser trochanter.
Yes.
The A23s are those who extend more than a centimeter distal to the lesser trochanter, which doesn't seem to be the case here. So this looks like an A22. And this is one of the difficult fractures to treat. And you basically, this is what I was saying, you can manage this either way. There is my colleagues who would look at this. There is a reasonable amount of lateral cortex here. They would just do a DHS, and they are not wrong. But let me show you what I have done. So put the fracture on traction. If in doubt, put the patient on traction table. Don't start until you look at the traction film. So what we can see here, the entry point where you were going to go with the DHS is broken. So going through there is not really something that I would be keen on, okay? We put in traction, it's gone into varus. I'm not going to leave the fracture like that. And we can see that this is a trochanteric where the extension of the fracture to the basal neck. So this is a fracture that is difficult. So I started with this position in varus. I was not happy with it. So I increased the traction. I ended up with some distraction in the femoral neck. So applying the nail, I decided to go for a nail because I think this is my preference in these fractures. I go in with the nail. So the nail has gone in and the lateral cortex have opened up a little bit. That's why I'll give you a recommendation at the end of this talk to say, choose your weapon, know your weapon. Now this is a TFN nail with a compression distraction device. I can use that device to push this fragment back into place. So this is very helpful. As I said, know your weapon. Now you can see it's almost completely reduced. I've passed in my guide pin. Okay. So the screw is in, adequate depth. Then I have a compression device on this nail that allowed me to pull this fragment backwards to achieve this reduction. and then with the set screw, I can lock my nail in. Now, that's what I'm saying is you need to know your tools. You need to choose your weapon and know how to play with it, because that is going to get you out of difficult problems, and you can get results and make sure that your patients are well fixed. Medical complications. So let's talk now. We've talked about the fixation of these fractures, how to assess them. What complications? I mean, the orthogeriatricians provide a magnificent service. In my practice back home, when you had a difficult elderly patient and used to ask a colleague to come and give you a medical opinion, it's really important with having the orthogeriatrician's ward. This is what they have to deal with. This is all the complications, which basically everything in the book. What about surgical complications? What could happen with these patients? You could have infection. Infection rate is 1 to 2% in the UK. You always have to consider deep infection in a failed osteosynthes. Looking at an X-ray like this, there's telltale signs there's something not quite right here. And this is not a revision procedure. This is just a primary procedure who took more than usual in terms of operative time. In elderly patients, you're not necessarily going to find high inflammatory markers or high white cell count or high temperature. You can have an occult infection that the only way to pick up the infection is deep samples through revision surgery. You could have AVN. AVN is not very common in trochanteric fractures. This is not like the neck of femur fractures. And it doesn't seem to be dependent on your choice of method of fixation. It's more dependent on how the patient have sustained this injury. You could have heterotopic ossification. I mean, the significant, according to Brooker's classification, the 3 and 4s, which are likely to give patient pain and limitation of movements, only 11%. But nevertheless, you have to consider if you do spot them somewhere between 3 and 6 months, what you're going to give the patient. Most probably some non-steroidals rather than radiation. What about mechanical failure? This is what we worry about day in, day out. Is this fixation going to fail? So fracture displacement with secondary loss of fixation. Now there's two separate entities, what we call screw cutout or cut through. So cutout is a circular movement with damage of bone of the femoral head and going into the acetabulum. And cut through is usually a perforation. This could be associated with nails as well. Contributing factors is patient's high BMI, osteopenia, vitamin D deficiency, as well as local factors, lack of blood supply, radiotherapy. What about failure of the implant? Again, I'll say it again, that the most researchers would agree that the extramedullary implants in subtrochanteric fractures have got a high rate of failure. It doesn't matter how strong your implant are. Any implant with a sufficient number of cycles of loading will fail if the fracture doesn't heal. There is a particular failure pattern with nails. Always, if you've done an intramedullary nail, look for your distal fixation, because normally the distal fixation would fail before the proximal fixation. They sort of auto-dynamize themselves, so bear that in mind. I don't particularly like the reconstruction nails, just because they have a method of failure named after themselves. And when I hear that these nails have got a particular method of failure, that doesn't fill me with confidence. What they call the Z effect, or the reverse Z, with one screw moving in and one screw moving out. Now, these are separate occasions. Now, we've blamed everything. We've blamed the patient. We've blamed the implant. Let's blame ourselves a little bit. Now, looking at this fracture, looking at the fracture on the top, there's a considerable sagittal plane deformity that has not been fully corrected, and the nail now is supporting the deformity rather than supporting the fracture. Again, my advice, reduce your fracture fully before you fix them. Looking at the image below, this is satisfactorily fixed, but if I'm going to be ultra critical, these are images from the net. These are not my images. These are not anybody images. These are just images that I wanted to give an example with. It's a very big ask of the human body to heal all that, although it can happen. But then if you don't correct the coronal deformity, you will end up with a lag screw that is superior in the head, and the fixation is going to be weak. So bear that in mind. So recognizing the full fracture pattern, recognizing lateral wall insufficiency, adequate correction of sagittal deformity, inadequate correction of coronal plane deformity, and the tip apex distance. These are your factors. Now, to summarize, assess your patient thoroughly. The team approach, MDT approach. Small details can make a huge impact. A patient with previous MRSA colonization, very trivial thing. You can have an MRSA infection. Bear that in mind. Keep your classification and guidelines in mind. Use your weapon, know your weapon. Aim to mobilize all patients fully weight bearing. This is very important. These are elderly patients. They won't do well when you tell them partially weight bear. You just need to fix them to the best of your ability to get them going. If you have a complication, you have to study it. Sit down and see what happened here. Is it mechanical failure? Is the failure of biology? What type of non-union is that? What really happened here? You need to sit down and discuss that to the depths. You should have a friend that to discuss these things with. You don't keep, if you have a complication, don't keep them to yourself. You need to discuss with somebody. Revision surgery is not easy. Are we going to speak about management of failed proximal femur fracture surgery? That's a topic of their own. That's our next talk, bi'Iznillah, with Dr. Muhammad in the next time I see you, because that's another very big topic. It's a very complex topic, and the choices are very complex. Thank you very much.
Thank you so much دكتور أيمن for المحاضرة الأكثر من رائعة بصراحة دكتور أيمن. يعني حضرتك مش just enumerating التوبيك، ولكن حضرتك بتعرضه من الكلينيكال point of view، did your own experience، الكلينيكال tricks. محاضرة رائعة بصراحة دكتور أيمن. We are waiting for the next session إن شاء الله. شوف حضرتك يعني تحب تقولها إمتى وإحنا جاهزين يا فندم.
اللي تؤمر بيه يا دكتور محمد.
العافية بيه، العافية بيه، ده شرف لنا.
انا يعني كريدت لحضرتك المجهود اللي انت بتعمله في الميديكال اديوكيشن.
العفو يا دكتور ايمن.
ثوره في التعليم الطبي، وانا يسعدني ان انا اساعد معاك.
احنا سعداء بوجود حضرتك معانا، وده شرف كبير لنا.
شكرا.
دكتور سعد، you are the moderator with Dr. Ayman.
Thanks a lot, Dr. Ayman Sorial, for this nice lecture. You talked comprehensively about the anatomy, biomechanics, deforming forces, assessment, and management of the proximal femoral fracture. There is some questions. The first one, do you prefer to use the proximal femoral nail in supine position or in lateral decubitus position?
I always apply these on traction table in supine position. The problem with the lateral position that you would struggle to view the lateral projection X-ray in the lateral position, and you lose the advantage of traction. The traction itself can work with you or can work against you.
Yes.
If you're planning an open reduction of the fragments, my advice is you not to apply very tight traction. Allow your patient a little bit of laxity. That will allow you to play with the fracture fragments and do an open reduction and then proceed with your nail.
Okay, another question. How can you correct the flexion deformity of the proximal fragment in proximal femoral fracture while the patient on a traction table are used to open the fracture site?
The apex of these deformities are at the level of your lag screw, believe it or not. And you normally would open an incision about 2 or 3 centimeters to put in your lag screw. If you extend that a few more centimeters, you could very easily approach the fracture site and correct your deformity. I do use a small lateral approach to correct the deformity, which I think is very much warranted.
Okay, another question.
Dr. Saad, may I have a comment, please, Dr. Ayman?
Okay, yes, of course, sir. Yes, yes, sir. Yes, sir.
May I have a question for you, sir?
Of course.
Dr. Ayman, sometimes we use a rigid reamer to manipulate the proximal fragment and reduce it and make the reduction easy. Do you recommend this or not, sir?
I think this is all very valid tools if you can do that. But when you look at the case that I presented, you had a flexion deformity in the proximal fragment of about 45 degrees. And the joystick technique is very well used and it's very successful, and I can use that, and sometimes I use my awl to establish that. But if you've got soft tissue in between, that is not going to work. And the thing is, you just need to get the reduction right before you start your nail, before you create your entry point. Because once you've created your entry point, there's no return.
Thank you, sir.
Another question, when to start with pairing, sir? Regarding nail and DHS. Do you have any recommendations?
I weight bear these patients second post-operative day.
Okay. Another question about the Z effect.
Okay. What about the Z effect? I don't use that nail, so I avoid the Z effect altogether. There is a number of research out there explaining the biomechanical background to why the Z effect or the reverse Z effect. I used to use the gamma nail, and I'm now using the TFN, so I don't need to worry about that.
Okay, sir. Another question about what if the guide wire penetrate the head of the femur? Does it make any difference at the follow-up regarding the osteoarthritis in the hip joint?
Once you penetrate inside the head, I mean, if somebody tells you that his wires never penetrate in the head, I don't think this is quite true. I think eventually we would like for the guide wire not to penetrate the head, but it can happen. If it happens, it's not a big deal. You get an area of osteonecrosis, and until we have an MD thesis with somebody looking at patients who had a DHS fixation and do a hip arthroscopy at the time of removal of metal to look inside the joint and see what actually happened, we would never know. But that is a good research question, and the way forward is to do a hip arthroscopy when removing metals following fixation of the proximal femur.
Okay. Another question. Somebody asking about your post-operative protocol for proximal femoral nail, sir.
As I said, all patients would have thromboprophylaxis. All patients, well, I say all patients, most patients would be allowed fully weight bearing on day one post-operatively. I would get routine monitoring bloods, full blood count, and kidney functions on the first post-operative day, and they would be allowed to weight bear with physiotherapy support.
Okay. Another question about the lateral cortex thickness. Sometimes it's less than 21 millimeter, and this is against the use of DHS. What if the fracture site was at the level of the leg screw for the nail?
If your lateral cortex is broken at the level where you put your entry site for the lag screw, that in my books means that I'm going to change my plan and use a nail.
Okay, sir. Thanks a lot, sir. No more question.
Thank you so much, Dr. Ayman, for joining us tonight. Merry Christmas, sir, and Happy New Year. Thank you so much, Dr. Ayman.